Hi, everyone. We're at the top of the hour, so we're going to get started with our very exciting live webinar for today. My name is Christina Asa. I'm a scientific application specialist here with Fujifilm Visual Sonics in Toronto. Today, our talk is Quantitative Ultrasound and Photoacoustic Imaging of the liver fibrosis. And our speakers are Dr. Laith Sultan and Dr. Mrigendra Karmacharya from the University of Pennsylvania. I'd like to give a few notes about today's webinar. A recording of the webinar will be made available after our live session today. All lines are muted for the duration of the webinar, so please use the Q&A button at the bottom of your Zoom panel at any point throughout the presentation to ask your questions. We will have a question period at the end of our presentation. We expect our presentation to be about 35 to 45 minutes in length with 5 to 10 minutes of questions at the end. Without further ado, I'll introduce our speakers. Dr. Laith Sultan received his Doctor of Medicine from Al Nahrain University, Baghdad, Iraq in 2003. After medical school, he interned at Al Qadimia Hospital in Baghdad and then joined Royal Medical Services in Amman, Jordan to train in diagnostic radiology with a focus on ultrasound imaging. He obtained a graduate certificate in global health from Johns Hopkins University Bloomberg School of Public Health in 2017, followed by a Master's of Public Health with a focus on informatics and global health. He currently works as a research associate of radiology at the University of Pennsylvania Ultrasound Research Lab, or Dr. Sandy Segal's lab. Laith's extensive background in clinical medicine and public health has prepared him well to conduct translational research. His early projects dealt with improving the diagnostic accuracy of ultrasound imaging for breast and thyroid cancer using computer analysis and machine learning. Dr. Sultan has been active in conducting preclinical research as well. His studies have shown that by varying the wave properties of ultrasound, it is feasible to both image and target tumor vasculature in real time. The translation of this method to the clinic to both treat and image tumors simultaneously would represent a novel, non-invasive method of image-guided antivascular treatment of tumors, similar to current approaches involving transarterial embolization therapies. Our second speaker is Dr. Mrigendra Karmacharya, who is a biomedical researcher currently working at University of Pennsylvania Ultrasound Lab, or Segal Lab, in the Department of Radiology at Perelman School of Medicine. Dr. Karmacharya graduated from Tribhuvan University, Kathmandu, Nepal, with a bachelor's degree in chemistry and master's degree of science with chemistry major. He then joined Inha University, Incheon, South Korea, where he graduated with a PhD in bioinformatics and biochemistry, specializing in molecular biology, biochemistry, and bioinformatics. Mrigendra's top skills include operating low-intensity ultrasound waves in various modes, encompassing a wide range of ultrasound frequencies, intensity, burst modes, and inclination time, with or without incorporation of ultrasound-enhancing agents such as microbubbles or chemical drugs for disease treatment. He has developed therapeutic low-intensity ultrasound for the treatment of various therapeutic conditions, including cancers and brain diseases. His research holds a unique place in the field because use of non-invasive, low-intensity ultrasound to treat liver, brain, and eye diseases has minimal side effects and holds huge potential for clinical therapeutics. The skill set he uses in his research is unique as it involves using low-intensity ultrasound rather than the conventional chemical drugs or radiation therapies. This technology involves utilizing the mechanical and/or thermal energy of ultrasound to cure the disease non-invasively and holds great possibilities as it can be performed alone or in combination with existing therapeutic modalities such as chemical drugs or radiation therapies. So without further ado, I'd like to pass things over to Dr. Sultan and Dr. Karmacharya.
Yeah, thanks, Christina, for the nice introduction. I'll start sharing. Yeah, thanks, Christina, for the nice introduction. First, I'd like to thank Visual Sonics for giving us this opportunity to present today and for having us today, both my colleague, on behalf of my colleague, Dr. Karmacharya, and myself. So our talk today is about quantitative ultrasound and photoacoustic imaging of liver fibrosis. In the first part of the talk, we will give some background about liver fibrosis as a disease, its prevalence and impact, its pathophysiology, and we will talk a little bit about the current diagnostic methods and the role of imaging of the liver fibrosis. Then we'll move to the experimental design of our studies, which include the animal model, the imaging studies, and the quantitative image analysis. Then my colleague, Dr. Karmacharya, will discuss the findings and the results of our studies, which include both photoacoustic imaging and quantitative B-mode imaging and histopathology validation. Liver fibrosis is a major public health issue. So according to CDC, number of adults with diagnosed liver disease is about 4.5 million, which is about 1.8% of the population. The number of liver cirrhosis cases in the United States in the year of 2017 was reported, not related to alcoholism, it was reported to be about or more than 64,000. The rate of alcohol-related liver cirrhosis in that year as well was about 5.9 per 100,000 population. The death rates from liver cirrhosis in general in that year, again, was 11.6 per 100,000 population. Liver fibrosis is a global health issue. So there are countries around the world with very high prevalence in liver fibrosis and cirrhosis. So countries, as we can see on this map, countries with red color and dark orange color have more than 2,500 per 100,000 population, which is in prevalence, which is pretty high in comparison to the United States. However, and as we can see in the map on the right side, the cases, the prevalence of cirrhosis and its end-stage hepatocellular carcinoma has been increasing within the last 2 decades. And in all states. In terms of mortality, liver fibrosis represents the 12th leading cause of death overall and the 5th leading cause of death for patients between 45 to 54 years old. The numbers, again, reported by CDC, numbers of death was more than 44,000, which is about 13.5 per 100,000 population. In this map of the United States, here we can see the distribution of death rates among the states. States with red and dark orange in color have higher death rates, which are mostly in the Midwest, in comparison to lower death rates in the East Coast. In this bar graph here on the right side, we can see the distribution of death rates according to patient ages. Although liver cirrhosis and fibrosis is a disease that affects all ages, however, there are patients that are affected more than other patients. So patients between 55 to 85 years old have higher death rates in comparison to other age groups. So liver fibrosis is multifactorial. There are many factors that cause chronic liver injury and ultimately liver fibrosis. One of the most common factors is viral infections, including hepatitis B and C. Also, healthy diet and lifestyle can lead to what's called steatosis, which is fatty liver. This fatty liver or steatosis changes in a percentage of patients to what's called steatohepatitis. This inflammatory component of the disease with time changes to liver fibrosis and ultimately to cirrhosis. Of course, this is a simplified version of the etiology. With diet, there are complexities, but in our studies, we are more focused on fibrosis. The other factor, which is really an important factor that leads to chronic liver injury, is alcohol abuse. So again, all these factors lead to chronic liver injury, which changes into liver fibrosis with time due to accumulation of collagen. And this fibrosis progressed to cirrhosis, which is an irreversible stage, and ultimately change into hepatocellular carcinoma. I'll talk briefly about pathogenesis of liver fibrosis, as my colleague, Dr. Karmacharya, will go into more details about the pathogenesis. However, liver fibrosis is a complex, fibrogenic, and inflammatory process that results from chronic liver injury. So in response to liver injury, which is caused by the factors that we talked about earlier, inflammatory mediators lead to the activation of hepatic stellate cells. And these activated hepatic stellate cells lead to secretion of extracellular membrane proteins, which stimulate and triggers the liver fibrosis process. In this process, there are multiple molecular and cellular processes, including hypoxia, angiogenesis, and inflammation. These processes drive each other following an activated loop, as we can see here in this scheme, and lead ultimately to the progression of liver fibrosis. So moving to the diagnosis of liver fibrosis, biopsy is the gold standard, and there are multiple systems used for grading the findings from biopsy, including Metaver, which is widely used. However, biopsy has several limitations, being invasive with complications including pain, intraperitoneal hemorrhage, infections, and also it is associated with the subjective scoring of pathology, and also associated with sampling error, where there are lower differences seen in Metaver grades within the same patients and with a high percentage. Currently, imaging plays a significant role in staging and diagnosis of liver fibrosis. All three modalities, CT scan, MRI, and ultrasound, have been evaluated and used for liver fibrosis. CT scan and MRI, both are very highly accurate for advanced fibrosis. However, both of them are limited by the less sensitivity in assessing mild liver fibrosis, and both of them are also limited by being expensive. Of course, CT scan has a high dose of radiation. MRI is limited by the fact that it requires post-processing. So this brings us to ultrasound, which really provides a number of advantages in comparison to other modalities. Being inexpensive, of course, it doesn't have any radiation, so it is safe, it's highly portable, it's widely available, and it provides real-time imaging and point-of-care service. However, it is limited by being operator dependent, and the image quality is affected by sometimes by the patient obesity and presence of ascites. Elastography use has increased lately and has been successful in staging and detecting fibrotic changes and became comparable to biopsy. There are different versions of elastography, and here on this slide we list some of the pros and cons of each version. So we can say that ultrasound elastography really exceeds other versions by the high accuracy and large area examined, and most importantly, the time taken, which is pretty short, about 5 minutes for the examination, and the low cost. In comparison to MRI elastography, which also provide a high accuracy in examination and a large area examined, but it is limited by the long time taken for the examination, which is about 45 minutes, and it is of high cost. Fibroscan, on the other hand, is limited by the small area examined and also doesn't provide real-time guidance. So, although elastography is successful, especially in assessment of the stiffness of the liver related to liver fibrosis, however, we believe that ultrasound is the modality of choice. Ultrasound provides a number of advantages, as we mentioned earlier. but most importantly, it provides a global view of the liver changes. However, again, it is limited by being user-dependent and largely evaluates qualitative structural changes, especially of end-stage cirrhosis. Other ultrasound modalities that have been evaluated include contrast-enhanced ultrasound that was used for assessing different stages of liver fibrosis by evaluating the hemodynamic alteration, but it was shown to be with lower sensitivity in comparison to elastography. Other modalities of ultrasound, including Doppler and photoacoustics, there's really very little known about them. So in our studies, our objective was to evaluate the use of quantitative ultrasound as an approach to overcome the limitations that we talked about earlier, represented by the user dependence and the qualitative nature of ultrasound assessment. And for this purpose, we use quantitative ultrasound imaging to monitor liver fibrosis changes longitudinally in a preclinical animal model. And as liver fibrosis involves structural and inflammatory changes, our hypothesis was that these changes can be monitored by using quantitative B-mode ultrasound and photoacoustic imaging as well. So in our studies, we used a diethylnitrosamine, DEN, rat model of liver injury. DEN is an established hepatotoxin that triggers the hepatic inflammatory fibrosis and carcinogenesis axis. This animal model, the DEN model, really provides a number of advantages, including being an autochthonous animal model, a naturally occurring animal model. It closely mimics human inflammatory liver disease, therefore providing a realistic assessment of liver fibrotic changes. And most importantly, it provides a principled approach for evaluating different imaging parameters in a controlled settings that are not often possible in clinical settings. So the rats that were used in our studies were given DEN in their drinking water for 12 weeks. During these 12 weeks, multiple imaging sessions were conducted to scan the liver at different time points, baseline, 5, 10 weeks, and then 13 weeks. And following the imaging sessions, we sacrificed the animals for histopathology validation. During imaging sessions, 6 standard imaging planes are used to scan different lobes of the liver. So we acquire about, on average, 6 to 8 images from the liver at each time point. These images are used for quantitative analysis. So we place about 6 to 8 region of interests. And from this region of interest, we extract quantitative features that describe the echo intensity and the texture features of the liver. Of course, the presets during the imaging sessions were kept fixed, and we used Visual Sonics Vivo 2100 in all of our animal studies. So first we'll talk about the quantitative B-mode parameters that we measured. Those included echo intensity, which is the average brightness of the liver parenchyma, and a hepatorenal index, which is the ratio of the liver brightness normalized to that of the renal cortex. Also, we looked at the regional and global heterogeneity of the analyzed tissue. And also we looked at other different texture features, including entropy, run length, and co-occurrence matrices. Photoacoustic imaging images were acquired at the same time points with B-mode ultrasound, of course, to monitor the liver disease progression. 4 parameters were measured. The first 2 parameters were about oxygen saturation, which included SO2 average, and which is the oxygen saturation per colored pixel, and also SO2 average total, which is the saturation of oxygen per pixel. We also looked at the hemoglobin concentration. So there were 2 parameters that included hemoglobin total average, which is the average hemoglobin concentration per colored pixel in the ROI, and hemoglobin total, which is the total hemoglobin concentration in all the pixels in the ROI. Of course, my colleague, Dr. Karmacharya, will give more details when he comes to the results section about these parameters. So coming to the histopathology validation, again, Metaver grading system is one of the widely used systems. So our vet pathologists that evaluated the slides use Metaverse grading system to assess the liver slides. In this system, the scores range between F0 to F4, F0 being normal and F4 being cirrhosis. And of course, in between ranges different grades of fibrosis. So now my colleague, Dr. Karmacharya, will take over to discuss and show the results and findings of our studies. Thank you.
Thank you, Dr. Sultan, for nicely introducing liver fibrosis as a disease and its global prevalence and its importance for diagnosis, and also introducing about the state-of-the-art technologies that are being used for liver fibrosis diagnosis. And as has been said earlier, we are trying to use ultrasound and photoacoustic imaging for diagnosis of liver fibrosis. And mostly, as many people are using ultrasound, but only mainly the qualitative aspect of ultrasound is being explored. But here we try to explore its quantitative aspect. And also we are introducing photoacoustic imaging to visualize changes in liver fibrosis. So our underlying hypothesis is as follows. So chronic injuries to liver will activate the quiescent hepatic stellate cells to activated form, where the quiescent hepatic stellate cells are transdifferentiated into myofibroblast-like structures, and activation of HSCs will trigger inflammation, which will drive hypoxia, and which will drive the angiogenesis, which in turn will lead to fibrosis. And there are several cytokines and growth factors are involved in these 3 different distinct processes. So these are the 3 distinct important phenomena that occurs in liver fibrosis. So, and they are not mutually exclusive phenomena, rather they are intertwined with each other. So there is positive feedback loops between them. So inflammation will increase angiogenesis, and angiogenesis will increase inflammation, and so forth and so forth. So our approach is something like this. So to visualize the angiogenesis or the formation of the neovasculature by using contrast-enhanced ultrasound imaging, and to visualize the fibrotic texture changes in liver tissue by using B-mode ultrasound, and to visualize inflammatory response of the chronic liver, inflammation by using photoacoustic imaging. So currently, for the talk today, we will be talking about only the B mode ultrasound and PAI technology that we use to visualize liver fibrosis. And contrast enhanced ultrasound imaging is something that we are working on. We are analyzing more data. We haven't published any data yet. So for the talk today, we will be focusing on B mode and PAI. So let's start with the basics of photoacoustics imaging. So what does photoacoustics imaging does is basically it maps the hemoglobin concentration. So hemoglobin it exists in two different forms. One is oxygenated form and one is deoxygenated form. And this oxygenated and deoxygenated form of hemoglobin has differential absorption spectra, and that's why they have a different photoacoustic signals. So photoacoustic imaging utilizes the differential light absorbance of this endogenous chromophore, namely the hemoglobin. And it can be, the visual sonics displays this photoacoustic signaling map in two ways. One is oxygenated form and oxygenated type, and one is the hemomeasure type. In the oxygenated type, we can see the oxygen saturation map, and in the hemomeasure type, it displays the hemoglobin concentration map. So for the display purpose, we will be using only the oxygenated type of the liver tissue. So in photoacoustic imaging, we have four different parameters, namely SO2 average and SO2 average total. So these two are the oxygen saturation, and SBT average and HBT are the hemoglobin concentration. So SBT average is something. So what we do is we first get the image and draw an ROI encompassing all the liver tissue that is seen in the image. And then we quantify the SO2 average and SO2 average total. So SO2 average is the oxygen saturation per colored pixel. So the colored pixels means it can be oxygenated or deoxygenated blood. So the more you go to the red end, it's more PA signals, and lower end towards blue is the lower oxygen saturation signal. So, but in the SO2 average total, it takes into account of all the pixels, be it colored or non-colored pixels. It takes into account all the pixels within the ROI. So in that sense, SO2 average is giving us information about the blood oxygen saturation, and SO2 average total is something telling us about the perfusion of the whole liver tissue. So same is with SBT average and SB total. So only difference is in this map, we are seeing only the hemoglobin concentration. So let's start with what our results. Actually, we divided our animals into two different groups. One is control and other is the DEN fed animals. So if you can see in the control panel here, so from the baseline to 5 weeks, 10 weeks, and 13 weeks, we don't see any significant amount of photoacoustic signals in the liver tissue. But for the DEN case, we compared to baseline, when we reached 5 weeks, there's a significant increase in photoacoustic signal here. And it goes up and is maximized at 10 weeks. And then, very interestingly, it starts to decline after 13 weeks. And we observed this phenomenon consistently, with peaking at the 10 weeks time point and then declining at the 13 weeks time point. So this is the qualitative explanation of our results. And if you notice here, in some of the rats, we see, as the time passes, there is increase in photoacoustic signal in subcutaneous region also. But however, it's not always the case. Sometimes we don't see any cutaneous manifestations here. But it should be noted that any liver disease has non-specific cutaneous manifestations such as itching or angiomas or the other skin disorders. So then we quantified the data. So our results shows here SO2 average and SO2 average total. So we can see the trend. These individual color represent individual rats. So we can see from baseline to 5 weeks, there's a slight increase in SO2 average and SO2 average total, and with peaks at 10 weeks and starts to decline at 13 weeks. And the same trend is observed in SO2 average total with the peak at 10 weeks and then starts to decline at 13 weeks. So this is the summary. So we plotted here for the control animals, there's no change so far for the SO2 average or in SO2 average total. But in the D and fed rats, there is a statistically significant increase in SO2 average and SO2 average total at the 10 weeks. And there is a slight decrease after between 10 to 13 weeks. But this decrease, however, this is consistently we found in almost every cases there is decrease in SO2 average and SO2 average total after 10 weeks to 13 weeks, but they did not reach statistical significance. So as I have mentioned earlier, that SO2 average takes into account of only the colored pixels, while SO2 average total takes into account of all the pixels within the ROI. So it turns out that the average of SO2 average total to SO2 average will give us the fractional area of the oxygenated hotspots. So then we calculated the ratio and plotted here, and we found that this ratio or the fractional area of the oxygenated hotspots also maximized at 10 weeks and then starts declining at 13 weeks, as summarized in this figure 2. So then we calculated the hemoglobin average and hemoglobin total. It shows the same trend with the increase in hemoglobin average total and total hemoglobin concentration from baseline up to 10 weeks. And then we start, then it starts declining at 13 weeks. So this is the summary. In control animals, we don't see any changes in hemoglobin total average or hemoglobin total, whereas in D and fed rats, we saw marked increase, which is statistically significant at the 5 and 10 weeks, and there is decline after 10 to 13 weeks. So a similar trend, and consistently we found the same trend in all 4 parameters. The same trend with the peak at the 10 weeks and start declining at the 13 weeks. So what does it mean? So it means in diseased liver, there is an inflammation. So inflammation will draw, or it asks for more, it leads to angiogenesis, and there's more blood flow in the diseased tissue. So that's why we are seeing a marked increase in photoacoustic signal. But after 10 to 12 weeks, it starts to grow the tumor also. So the time point between 10 to 13 weeks is the onset of tumor formation in the liver. So when there is a tumor formation in the liver, the tumors demands for more and more oxygen and nutrients, which cannot be supplied by the angiogenesis, and that's why we are seeing a little decline in photoacoustic signal. So then we also studied about the B mode ultrasound to see the echogenic changes in the liver tissue. And we found that in the control animals, there's no change so far. All the livers look normal and dark. There's no increase in any brightness. But in the DN-fed animals, on the other hand, we found that with the time, the echogenicity or the brightness of the liver starts to grow uniformly. So when we quantified this data, we found that the echogenicity and heterogeneity of the liver tissue starts increasing. So any increase in these numbers means there is an increase in coarseness and non-uniformity in the liver tissue. So echogenicity, you can see here, it increases from baseline to 13 weeks. And also heterogeneity also increases, which reaches statistical significance at 10 and 13 weeks, as compared to control groups where there is no change so far in both of these parameters. And both the echogenicity and heterogeneity, they represent the global distribution of intensity values in grayscale images. And some other texture features such as contrast and entropy, which accounts for the disorderliness of the distribution of the grayscale or the brightness of the images. We also found that there is uniform increase in the contrast and the entropy of the liver tissue. Similarly, the run length and absolute gradient, these are other texture features which accounts for the non-uniformity of the whole liver tissue texture, and absolute gradient, which measures the gradient-based features from each pixels compared with the neighboring pixels. So how each pixel is different from its neighboring pixels. So all these two parameters, both the run length and the absolute gradient, they are increased by DN. And then we looked at the liver-kidney interface. So if you can see in the control case, the the kidney looks brighter than the liver. And consistently for the control group, so from baseline to 5 weeks, 10 weeks, and 13 weeks, the liver looks darker and the kidney looks brighter. But in the DN-fed animals, initially at the baseline, liver is dark, but as time passes on, liver becomes brighter and brighter, and finally, the brightness of the liver after 13 weeks is comparable to that of the kidney. And then we quantified the echogenicity of the liver to see if it is changing over time. We found that in both the control groups and the DEN-fed animals, there's no changes in echogenicity of the kidney so far, but the hepatorenal index, the ratio of the kidney and liver to kidney ratio is increasing significantly in the DN-fed animals as opposed to that in the control groups. So this also shows that there is a uniform increase in the non-uniformity or heterogeneity and coarseness of the liver tissue by DN ingestion. So the formation of the fibrous tissue has been confirmed. We confirmed it by histology. So we can see here H&E staining and trichome staining is showing the diseased liver in rats. So a closer look here in the lower panel, we can see the control liver tissue. The cells looks very fine. But in DEN-fed animals, we observed the development of numerous septa with collagen deposits as shown by these arrowheads. So these all are the collagen deposits. And when we quantified the collagen deposits, we found that it increases innermostly, dramatic increase in collagen deposits between control and TN groups. So finally, we also observed the formation of HCC or the tumors after 13 weeks. So in conclusion, what we can say from our study is that photoacoustic imaging, it measures the increase in oxygen saturation and hemoglobin concentration induced by inflammation and angiogenesis during liver fibrosis non-invasively in real time, while B-mode ultrasound provides information on the liver fibrosis-induced tissue texture changes. So the integrated photoacoustic imaging and B-mode ultrasound imaging gives us the global picture of the architectural and functional and physiological changes in the liver fibrosis caused by DEN. So, and we look forward to using the integrated photoacoustic imaging and B-scan imaging, and also the contrast enhanced ultrasound imaging together in clinical settings in the future. So today's talk is basically based on our previous publications as listed here. And finally, I'd like to acknowledge Dr. Segal for his enormous help and cooperation. And also I'd like to thank our lab members, Susan and Ted especially. And we'd like to thank the organizer, Visual Sonics. And I'd like to thank the audience for your patience. Thank you.
Thank you so much, Dr. Sultan and Dr. Karmacharya, for that excellent presentation. I'm going to open the floor up now to questions. So please use the Q&A panel at the bottom of your Zoom screen to ask any questions you might have. We have had a couple questions already come through. So I know you ended your talk there talking a bit about the clinical translation. So this question touches on that. Can this technique that you've presented today be used to quantitate the liver injury in a human newborn exposed to parenteral nutrition?
So I can start maybe in responding, and maybe Mrigendra can elaborate. So, I mean, of course, our studies, the preclinical studies, has to be validated first in human studies, and there is actually a difference. I mean, in our studies, we're using higher frequency transducers, and with higher transducer, of course, we have the advantage of higher spatial resolution. But of course, there is also high biscatter also. With the lower frequency transducer used in a human, we'll see less biscatter, of course, but in the same time, there is a difference, and this is also, we reported that in one of our papers. There is a difference in the microstructure of the liver between human and animals. So, and human usually have twice the thickness of the fibrous tissue in comparison to animals. So this also adds to the backscatter. So we believe this really helps the translation process. I mean, and it is
Sounds like Laith, your audio must have gone off. I don't know, Dr. Karmacharya, do you want to fill in there? Mrigendra?
Oh yeah, hello. Yeah. So something.
Yeah, it sounds like
weird happened. Okay.
we sounds like we lost Laith's audio there. Do you mind filling in the rest of that question?
Yeah, I think he covered the thing.
Okay, great. Thank you.
Yeah.
So the next question, and we'll stay on the clinical theme here. How do you envision applying photoacoustics in the clinic and for
Yes,
humans?
that's a really, really good question. And photoacoustics, because it's a very new platform modality for imaging modality, it is being evolving. And the major issue to translate photoacoustics in human clinic is the depth issue. You know, it cannot penetrate in deep tissue. That's had been a consistent hurdle to be able to transfer photoacoustics in clinical modality. But yeah, again, as I mentioned, it's evolving. That's what I can say.
That's great. And I'll just add there as well that we do have another system, our Vivo F2, that's brand new, and it's able to do both low and high frequency imaging. So if this is of interest, then please contact us and we can explore that further with you. So again, we have a lot of clinical translational questions, which is great. How come when using human liver imaging with low frequencies, like 3 to 5 megahertz, the textural changes, like changes in brightness, are not observed to be increasing that significantly compared to what you've shown in this presentation here? Any comments on that?
Yes, thank you for the question. And this is really an important question. I mean, of course, I mean, with the different frequencies, I mean, there are different, also we see a difference in so with higher frequency, again, with what we use with animal studies, we have higher resolution, of course. But there is a limitation of the backscattering. So with human, there is less backscattering. So, I mean, it has to be validated, of course. I mean, in human too, we don't know exactly, but we think, I mean, the difference in the tissue and the microstructure of the liver can have a relation to that. Yeah. Do you agree, Mrigendra? If you have anything.
Yeah, I think so. Yes.
Yeah.
Great, thank you. The next question, do you use elasticity of the tissue in any of your studies?
No, we don't. We do not take account of the elastic or mechanical property, but we use the texture features, which again, texture features in a way, not directly, but indirectly gives us information about the elasticity or the, stiffness, because stiff tissue maybe it is coarse, not smooth. So, but again, it doesn't provide the direct evidence of the elasticity.
Okay, great.
Can I add something? Sorry.
Yeah, of course.
Yeah, so I mean, and we think also, I mean, so again, as Mrigendra said, I mean, elastography really is successful, as we said, but it doesn't look at, so it is a measure of the liver changes in fibrosis just from the changes in the stiffness. But we really, with ultrasound, we really look at more at the architectural or the structural changes. So it really gives us a better look and more global look. And also with photoacoustics, we are looking at physiological changes. So we believe that really ultrasound can add more information to elastography, and both of them can complement each other.
That's great, thank you. I know you provided an explanation why the SO2 and the hemoglobin levels decreased from 10 to 13 weeks with the formation of the tumors. Were you able to actually visualize any of that tumor formation with the ultrasound imaging?
No, actually not. So we try to visualize or to differentiate if there is a tumor formation using photoacoustic imaging, but for our study, we didn't observe any photoacoustic changes in the tumor so far.
Okay, great. The next question is, you mentioned you were going to be using microbubble contrast as the next part of your study. What would you hypothesize you'll find by looking at these livers with respect to the other results you've already presented here?
Yeah, so the hypothesis in using the contrast enhanced microbubbles to visualize liver fibrosis is that in liver fibrotic tissue, there is neovascularization taking place. So we think that with the help of the contrast agent, we will be able to visualize the microvessels that are being formed in the liver tissue as opposed to the control liver.
Great. And could you elaborate, this is more on the methods, more on how the liver heterogeneity was scored in your study?
Okay, so liver heterogeneity, we used a software called Mazda. So it uses the different mathematical models to calculate the texture features using various matrices, yeah. So basically we used Mazda.
Okay, great. And the next question, what is the resolution needed to observe a significant difference in the liver texture?
I don't fully get this.
So you mean, the question means the frequency? He's asking about the frequency or?
Yeah, I mean frequency, which lends to resolution, I assume.
So the frequency we use, sorry, it's about 21 megahertz, right? So this is designed for.
Yeah. And for the photoacoustic imaging, we use 9 to 18 megahertz broadband transducer. So
yeah, with this frequency, again, we get high resolution, high spatial resolution. Yeah, but we're not sure. I mean, so about, I mean, what resolution he's looking for, or she, sorry.
Yeah, I'm not sure either. It might warrant, you know, the minimum resolution needed would probably warrant a study to see at what point you stop seeing differences once you know, decrease your frequency and thereby decrease your resolution. So yeah, I assume you didn't venture down that. You used the frequencies that were available.
Yeah, because I mean, for preclinical studies, we have the ranges of the frequencies in this range, of course. I mean, about 21 megahertz, and these are designed again for preclinical studies.
Yeah, and we do have frequencies up to 50 megahertz on our preclinical system, which gets resolution down to 30 microns. And so if that's what's needed.
Yeah, of course.
Okay, the next question is, how do you standardize your imaging planes across animals when you're looking at the livers?
So, and as I mentioned in the presentation, the presets are kept fixed. So gain and TGC is all kept fixed for the same animal, of course, and for all animals. So the settings shouldn't be an issue when we look at the changes in the echogenicity and the texture. Yeah. So otherwise, I mean, so each animal is controlled for itself, and also it is kept for all animals. So it shouldn't be an issue if this is the question. Maybe Mrigendra has something to add.
Yeah, actually, for both the photoacoustic imaging and sonographic, I mean, B-mode imaging, for each animal, for each individual animal, at the baseline, we fix some settings, the presets and all parameters there, and we keep it fixed for that particular animal and for the longitudinal studies. So I don't think setting would be a problem here. Yeah.
Okay, great. And we'll just do one final question as we're running short on time here.
Sure.
The question is looking at kidneys. So do you have any tips as far as useful landmarks in identifying the kidney so that one doesn't include kidney when trying to look at echogenicity of the liver?
So in our study, we always find kidney to be brighter than liver. So if the question is how to differentiate between kidney and the liver, certainly kidney looks very bright. And also you can see from the shape of the kidney, you can see it when you scan the animal, it will be very easy to see the kidney, I think. And yeah, for the liver versus kidney is always bright.
So
can
I add something just very fast? So I mean, what we use is hepatorenal index. So this is really a widely used principle for normalizing the changes in brightness of the liver to that of the kidney. So it is used in clinical, actually. Although, again, as Mrigendra said, I mean, the kidney of the animals look a little bit different in terms of echogenicity when we compare it to that of human. But still, if the question is about the landmark, it just should be easy to get the kidney, actually. And in analysis, because when we obtain the image, so we focus on the interface between kidney and liver. So, and when we analyze the image, it should be very easy to, the landmarks are very differentiable, and yeah, so it's straightforward.
And I'll add that we do have on our customer portion of our website, we do have imaging guides available, and one is geared towards kidney imaging. So you can, I encourage you to check that out, or you can always contact us and our application scientist team can give you a hand in making sure you're comfortable with identifying the kidney. So just as we're wrapping up here, someone did ask about the results that you've published here, and are they able to find the publications or get a handout of it? So yeah, it
actually,
was on that slide there.
Yeah, in the slide in the reference section, I mentioned that one. So yes, the results have been published, and I think they are accessible.
Yeah, so I'm sure you can search in PubMed, or we'll also be sending this recording to all of our attendees here, so you can look, and it'll be available on our website as well. You can look at that final slide that Dr. Karmacharya shared, and it will show those references specifically there. Okay, so we're heading to the top of the hour again. So I want to take this opportunity to thank you both very much for this great presentation. We had a lot of really nice engagement.
Thank you.
So it's so nice to see all the interest swirling around. And obviously, I'd like to thank everyone for joining. Just a few last notes from us here. Again, as I mentioned, we do have a resource portal available for our customers. If you wanted to look up any imaging guides or anything like that, they are available on our website. You can also submit a support request if you'd like to speak to any of our technical or scientific experts. Please check our website for postings of new webinars that will be upcoming. You can find us on all the social media channels and at many virtual conferences that are coming up. And then we do have a video training portal available called the Learning Hub, which I encourage you to check out. So with that, I'd like to thank you all very much for attending today. And thank you again for the great presentation, and we'll see you next time.
Thank you so much. Thank you. Have a good day.
Thank you, Christina, and thank you, Mandy.
And thanks to the audience. Oh, thank you so much. Thank you.
Thank you. Bye.